Welcome participants. I welcome you all to the third AOAF webinar. Today's talk will be on treatment of ankle fractures in low-income countries. I am Dr. Kibria, a consultant orthopedics, Dhaka from Dhaka, Bangladesh. I work in two hospitals in Dhaka. One is the Apollo Hospital, which is a JCI accredited hospital. Another one is a Japan Bangladesh Friendship Hospital, which is for general people and for low-income groups. I have with me Dr. Leonard Banza as the moderator. I request Dr. Banza to introduce himself. Dr. Banza, please.
My name is Leonard Banza, orthopedic surgeon at Kamso Central Hospital. This is in Lilongwe in Malawi. I will be the chat moderator for this webinar. Therefore, I would like to request you to submit your questions, and we'll try our best to answer to some of them live, but also some of them offline. It will depend on how much time we have. Once again, most welcome to this webinar, and thank you, Dr. Kibria. Over to you.
Thank you, Dr. Banza. For today, for the next 1 hour, we have the agendas as you can see. We'll talk brief introduction on the AO Alliance Foundation. We'll have the webinar proper on the treatment of ankle fractures in low-income countries. We will have live question and answer period. After the live question session, we'll go offline and chat answering further questions. So what is AO Alliance Foundation? This is a non-profit organization who is dedicated to look after fracture care in low-income countries. I repeat, the low-income countries. That means people where the income is poor cannot afford treatment facilities by themselves. Neither the government helps them a lot. So in that situation, to give them the best fracture care, AO Alliance Foundation is working on it. They build the capacity of the medical professionals by research, education, and building of infrastructure. This webinar is also a distant learning part of the AO Alliance Foundation, as you can see. So today's talk will be on treatment of ankle fractures in low-income countries. Ankle fractures commonly occur following a fall or twist of the ankle. This is the scenario we'll be showing to you in a low-income country. The 25-year-old man fell, twisted his right ankle. As you can see in the x-rays, both the malleoli are fractured. You can see in the fibula, the fracture line has gone up. There is a posterior malleolus and the talus is displaced posteriorly. So after that, he was unable to seek medical attention for different reasons, for local problems, social reasons, economical condition. So he reached the district hospital 3 weeks post-injury. He was unable to walk, the injury was closed, the neovascular status was intact. So after 3 weeks, the district hospital doctors, they had treated them. So I put to you a question number 1. Do you agree with the following statement? One of the biggest problems with ankle fractures in low-income countries is the challenge of late presentation for treatment. If you say yes, you can click A. If you say no, you don't agree, B. Or if you say only on occasion, you can click C. So now it's voting time starts. Please put your votes. So as you can see, most of the people has commented yes. That means this is definitely a problem in the low-income countries, late presentation, which is really a challenge. We have to deal with this challenge. How we can do that? That is one of the issues today. So you see, after the patient I had shown you the x-rays, he reached the central hospital. After 3 weeks, he was taken care of, but look at the implants. They have used the malleable wires. There is only one screw, no plates. Even you can see they had to transfix the ankle joint to a K-wire to maintain the reduction. So this is the present day scenario in low-income countries. So after this today's talk, we'll have a learning outcome. You'll be able to recognize that non-operative treatment of ankle fractures requires close follow-up. You should be able to communicate clearly with the patient and the family the treatment plan, expectations, and the referral system. That means when you need, the patient must be referred to a higher center for proper treatment. You should be able to describe and apply appropriate non-operative and operative treatments of ankle fractures. That is the key goal, that you must know when to operate and when not to. At the same time, you must understand the pitfalls of syndesmotic injuries. Syndesmotic injury is a very important part of the ankle injuries and their potential to lead to poor outcomes. So after today's lecture, I hope you'll be able to appreciate these different parts of the ankle injuries. So to overcome all these problems, we have divided our topics on the 5 different topics. First one is the anatomy of the ankle. Second one is the X-ray evaluation. Third one is we'll classify the ankle fractures. And the fourth, we'll plan the treatment of ankle fractures. And last 5, the difficulties encountered in low-income countries. Anatomy, I think you all know. Just simply to refresh our knowledge, the ankle is formed by the tibia and fibula with the talus. These are the 3 bones that form the ankle. But the important part is that the articular congruity is the key to the treatment, because without articular congruity, cartilage will degenerate and lead to post-traumatic osteoarthritis. The ankle fractures, as you can see, ankle fracture includes 2 joints. The tibia fibula with the talus and the syndesmotic joints. So these 2 joints are involved in the ankle fractures. There may be a fracture of a single bone, there may be fracture of the multiple bones. So single bone may have stability. When the multiple bones are involved in the fracture, you can have instability. So in ankle fracture, you have various variants of injuries starting from stability to instability. I wish after this today's talk, you'll be able to identify which one you can treat conservatively and which one you can treat operatively. The doctors have named the fractures according to their broken bones, area of broken bone. Like if the medial malleolus with the deltoid complex, as you can see, number 1, this is the medial malleolus, the deltoid complex. If this area is fractured, we call it medial malleolus fracture or the rupture of the medial ligaments. If as you can see, number 2, the lateral malleolus is fractured with the lateral ligaments, like the anterior talofibular ligament or calcaneofibular ligament or posterior talofibular ligament with the talus may be fractured. In number 3, if there is a rupture of the anterior syndesmotic ligament, there may be a bony avulsion, or there may be a posterior tubercle fracture along with the posterior syndesmotic ligaments. So we can have 4 bony fragments with or without ligamentous injuries. So there may be a single bone fracture, there may be a multiple bone fracture, which will lead to instability. So now we know the anatomy. After we have taken the patient history and clinical examination, we have to evaluate them on X-ray basis. The X-rays is a key guide because in low-income countries, you may not be able to get CT scan or MRI or C-arm facilities. So X-ray may be the maximum facilities you can have. 3 radiographs are to be taken. These are the best, 2 orthogonal views, the AP and lateral view, and the special view is the mortise view. What is our aim in the radiographs? We must look for the fractures of 3 malleoli, the medial, lateral, and the posterior malleoli commonly. You must be able to appreciate if there is a talar shift, and you should be able to diagnose the rupture of syndesmosis, which we call it diastasis. At times, you might need further imaging, like stress view of the ankle. Either you can take a gravity stress view or you can take a manually stress view. That in need, if you want, you can take it. But first three views should be mandatory to diagnose all the lesions of an ankle. So just look at this orthogonal views, the AP and lateral. This AP view we can see there are few things I would like to show you so that you can identify if there is a syndesmotic rupture or not. First one is the tibiofibular overlap. You can see this arrow. This is the area, the tibiofibular overlap. This is usually 10 millimeter. If the size decreases, so you can suspect syndesmotic rupture. This is the tibiofibular clear space. It is usually 5 millimeter. If this gap increases, you can suspect syndesmotic rupture. The third one, we can see these two parallel lines above the talus, upper border, and the plafond. Usually they are parallel, or they can make an angle of 2 degrees only. If the angle increases more than 2 degrees, you can suspect talus shifts. In the lateral view, as you can see, you can appreciate the fractures in the fibula that may be oblique, going upwards, or which place, and you can appreciate the talar displacement as well. So these two views can give you a lot of information. Now comes the mortise view. What is a mortise view? This is a special technique of taking the AP view X-ray. You know that fibula is placed a little bit posterior to that of tibia. To bring both the malleoli in intermalleolar line in line or at right angle with the X-ray beam, we rotate the ankle 15 to 20 degrees internally, but not at the ankle. The rotation must have come from the pelvis, so that these two lines, the intermalleolar line comes at right angle. So once you take this X-ray, you can see the joint space all around the tibia. It should have equal breadth all around. That is another guideline to appreciate any talar shift is there or not. So now I will have a second question for you. Why is the ankle mortise view important? You can see the answers. Now it's your time to vote for it. You have few seconds to answer for it. Your time starts. So it's really interesting that 90%, more than 90% have answered the correct one, that you look at the tibio-talar joint space. Anyway, so now you know why this tibio-talar space is so important. So next one, based on after you have diagnosed clinically that and you've taken the X-rays, now you need to classify the ankle fractures. We need this classification to plan management, to communicate, and to keep the document in which fracture, what was our decision. There are many classifications, but AO and OTA fracture classification, they have accepted the Denny Brown's classification as their basis. So, as you know, the tibia is known as an AO by 4, and the malleola is also known as 4. After that, they have reclassified. The further classification has been made depending on the fibular level of fracture, whether it is at the level of the syndesmosis, below or above. In such, A has been placed if the fracture is below the syndesmosis, B is at the level of the syndesmosis, and C is above the level of the syndesmosis. All the A, B, and C has been further classified on 1, 2, and 3 based on if there is a medial malleolus involvement or if there is at the same time medial malleolus plus posterior malleolus involvement. From A to C, C is more unstable. From 1 to 3, 3 is more unstable. So number increases, the instability increases. Number of fracture increases, bony fracture involvement increases, the instability increases. So that is one way to classify the fracture. This is just to present before you as a pictorial presentation. You can see A is infrasyndesmotic. You can see anatomically this is the tibial plafond, this is the syndesmosis is below that. So this is A. Accordingly, B is here and C is above the syndesmosis. Just to give an X-ray picture of the same thing, you can see this is A, this is B, and this is C. You can see in both B and C there is a chance of displacement of the talus. Talus is shifted laterally, so this is an unstable fracture. So far we have been discussing the unstable fracture with rupture of the syndesmosis. What is the syndesmosis? Syndesmosis is a fibrous joint at the distal near the tibia and fibula, but the tibia and the fibula are held by certain ligaments. There are three ligaments. One is the anterior tibiofibular ligament. As you can see, this is the anterior tibiofibular ligament. There may be posterior tibiofibular ligament and the interosseous membrane. So many a times these ligaments are ruptured along with the fracture of the bone of the tibia or fibula, which gives rise to shift of the talus and gives rise to instability. Unless you fix them, the talus shifts later on and gives rise to pain and osteoarthritis. So the word we have used diastasis, meaning when the syndesmotic ligament ruptures, we call it diastasis. That means diastasis is the tear of ligaments and the ankle mortise widens. So to identify and appreciate diastasis, you need to look very carefully at the X-ray. I have given you a few clues in the primary X-ray reading, how to identify diastasis or if there is a rupture. If they are not treated properly, it will lead to pain and arthritis, and the patients will be very much dissatisfied. How to recognize the ankle diastasis? There are two ways of diagnosing ankle diastasis. One is clinical examination, other one is an X-ray. Clinically, it is possible to appreciate diastasis by squeeze test. Like you can press the fibula with the tibia, and if there is a pain in the syndesmotic area, you can appreciate there may be a diastasis. There is an external rotation test. We can hold the tibia and rotate the hind foot. So externally, if there is a pain in the syndesmotic area, you can also appreciate that there may be a rupture in the syndesmosis. So along with the X-rays, clinically also you can appreciate the diastasis, rupture of the syndesmosis. So participants, please continue with your questions. Dr. Banza will be happy to answer your questions. So now we have come to the third question. What fracture can exist at the proximal end of the fibula and usually associated with an ankle fracture? Your time starts. So it's very interesting. All the participants have answered correctly mostly. Type C, Meshonnet fracture is the correct answer. Dear participants, Dr. Banza is waiting for you for your questions to answer. If you have any question, you put it in the chat box so that Dr. Banza can answer your questions. So after you have correctly answered Meshonnet fracture, now we need to plan how to treat ankle fractures. We have diagnosed the ankle fractures either stable or unstable. We have classified them into A, B, and C. We have further classified them into type 1, 2, and 3. Now we have to plan and decide which fracture needs which treatment, and along with any other factors are responsible or not. We are coming to that. So while treating, the main goal of reduction is to restore the articular congruity. Articular congruity maintains the cartilaginous growth. If the cartilage is not maintained, there is a degeneration. If the congruity is not maintained, the cartilage degenerates and leads to osteoarthritis. I told you before that. To have an appropriate articular congruity, fibula must be reduced both in length and rotation. See, if you see this picture, X-ray, there you can suspect. See, this tibiofibular overlap is very small, less than 10 millimeter. And the gap here, the tibiofibular gap, clear space is little bit more. And you can see there is a little bit more space on the medial side than lateral side. So you can appreciate there may be a syndesmotic injury. You need to take an X-ray of the uninjured ankle so that you can compare. Another point, if you have taken an X-ray, you can see this fibular beak must be smooth and continuous with the inferior tibial joint line. So you see, this is bony picture, that fibular beak, this is the fibular beak, as you can see. This is in continuity, in a smooth curve, there is no break in line. So if you have reduced the bones appropriately, fibula appropriately, this joint must form a smooth curve. So only then you know that you have reduced the fibula perfectly. So you need to decide when to treat operatively or when to treat non-operatively. First of all, we'll tell you a few words so that you can plan and treat patients non-operatively, which is one of our aim in low-income countries. When the fracture is undisplaced and stable, that means you have reduced the fracture or you have put a plaster for immobilization and taken chest X-ray after 7 to 10 days once the edema has reduced, and you can see there is no displacement. You can treat them conservatively. Clinically, medial ligament injury, you can press tenderness on the medial side. You can take a gravity stress view to identify if there is a medial talar shift or not. So in case of there is medial ligament injury, you can also treat them conservatively. There are certain other conditions like presence of contraindication to surgery. That means the patient itself is not fit for surgery. Either he has got cardiac problems or he has got some diabetic endocrine problems, which is a bar to the surgery, because we don't want to lose the patient for the ankle surgery only. The most important of all, but not the least, the soft tissue status of the local area. You must always appreciate and give importance to local soft tissue area. If the soft tissue is not suitable for surgery, you have to take that for to treatment, even though temporarily may be. So indications for operative treatment. So once we have discussed the non-operative ones, now we will telling you certain situations when you have to go for operative treatment. The articular fractures, when the fracture line has involved the articular margins, when there are displacements and unstable fractures. But the soft tissue condition must be suitable for surgery. That is the key guide. Unless the soft tissue is suitable, you cannot take him for surgery. So once you have decided to take the patient for surgery, you must plan preoperatively. Unless you plan, if you fail to plan, you are planning to failure as well. The first important part is timing of surgery. We have discussed so far the patient's general condition and the local area ankle condition, soft tissue of the status. All will plan, support you to guide and decide when to take the patient for surgery. Positioning. Usually patient is taken supine with a sandbag under the pelvis. So you can look into the lateral side. After you have reduced the fibula properly, you can take out the sandbag and do the surgery on the medial side. Surgical approach depends on the type of fracture. Reduction should be accurate, anatomical. You should use a tourniquet so that it gives a better visualization. The implant choice. Before the surgery, you must look into your implants, because in low-income countries, you may not have all the implants available. So you must keep a second line of defense in hand. K-wire, say for example, plate and screw is the best choice, but you must keep K-wire and circlage wire at the same time so that it can help you and come out of the surgery. Pitfalls and hazards. You should have proper implants for reduction and proper tools for holding. Otherwise, while holding or reducing, the fracture fragment might disintegrate or refracture might occur, or you might have an implant failure at the same time. The wire cutter, if you don't have proper wire cutter or wire bender, while bending or cutting them, you might be in trouble, or putting them inside may be in trouble. So you must look into the implants and instruments before taking the patient for surgery. See, this is an X-ray. So if you are shown this X-ray, would you like to take this patient directly to the surgery or to do for something? At least you should reduce it. And if you want to take him for surgery, you plan accordingly that we have told you just before. Look at this foot. This patient has an ankle injury, but the skin condition, can you take him for surgery? I don't think so. There are blisters, the skin is bruised. You must give him some time to heal. It looks like an orange peel. You can put an X-fix or plaster of Paris, whichever is available. But in such a situation, we prefer you put an X-fix so that you can take care of blisters at the same time. So you can put the X-fix till the skin heals like this. As you can see, it may take weeks, 1 week to 2 weeks time. Once the skin has healed, you have reduced it perfectly, then you plan and decide whether you need to take him for surgery or not. So what are the difficulties that encountered in LICs? We have so far talked about the principle of treatment. Now we are coming to difficulties that low-income countries will come across, many of you. Say 35-year-old woman twisted her ankle. Do you think we should see an X-ray like this? I feel it should be judged clinically, reduce it, and then send it for X-ray. Otherwise, if you put this foot like this, send him for X-ray and come back, if it takes half to 1 hour or 2 hours time, by this time the skin condition might disrupt, the vascularity might be compromised. So it is always better judge clinically, reduce them, then send him for X-ray. Okay, say for example, it has been reduced. So this is the closer look. You have the medial malleolus or the lateral malleolus. So the reduction films. So are you happy with this? So you need to do something more in future. Just have a look to this angle. Are we happy with this place? Let's see. So there was a compression on the inner margin. That means this must have happened during fracture or during reduction. We do not know. But the situation is, in low-income countries, the patient is unable to purchase implants. There may be surgeons not available. Operation theater may not be available. So in that place, the patient was put a long leg cast. Do you agree that a malleolar fracture should be treated in a long leg cast? You can put your questions, Dr. Banza. He is ready to answer for these. So in the summary, we can say that non-displaced fractures, we can treat them with plaster of Paris. Distressed fractures better be fixed, but you must have surgeon available, theater available, implants available, and the local soft tissue condition must be in favor of surgery. In some situations like lateral malleolus only, we can get good result with reduction and plaster, but you must carefully assess the X-rays for diastasis or have a check X-ray after week so that you can appreciate if there is diastasis or not. Especially fractures above the articular surface of the tibia, that means suprasyndesmotic ruptures, fractures, type C fractures usually need fixation. If you can diagnose diastasis, it's better to be fixed. The socioeconomic condition in low-income countries is that there may be varieties, but it is usually similar in most of the low-income places. One important part is that consider the cultural and social behavior of the patients. What is that? In many countries, patients do not want to go to surgery or hospital. They prefer their local doctors or local bone setters. One important part, once you have treated or incomplete, you have asked him to come after a couple of days, you may not see the patient for follow-up once again. Or your technical support in your area is not enough. You don't have C-arm, you don't have portable X-rays. The financial resources are also limited. The treatment depends on your knowledge of the injury. That means whatever the situation is, apply your knowledge to treat that patient. The norm for many of you may be that patients are presenting late because he was not referred early. The previous treatment was insufficient and it's making it difficult for you to treat. You can't have an X-ray. So once you have the patient in your hand, your treatment must be definite treatment. That means if you have got the patient early or late, you appreciate or decide, yes, you have put it non-operatively, so he will not need further any fixation or operative treatment. If you have no resources, it is essential to have the knowledge to implement the correct treatment. So now we'll have live question and answer session. Please submit your questions via the chat room. We'll continue to answer them. I will have Dr. Banza with me.
Okay, thank you, Dr. Kibria. The time you were presenting, I've received a couple of interesting questions, and then I would like to discuss with you. The first one, there is Yasin from Pakistan and Aishi from Kenya. They would like to know, because it was almost like the same questions, they'd like to know with the squeeze test or external rotation test, how do you do it because the patient is still in pain?
Thank you. It's a good question. Once the patient is in pain, we can give him analgesics. But you are very politely compress the fibula against the tibia. And the upper third, you have shown you in the picture. In the upper third, if there is a tenderness, he complains, okay, he feels pains in the syndesmotic area, you can suspect syndesmotic injury. And very politely, you hold the leg, and with the other hand, you try to externally rotate the hind foot. You must be very polite so that he can tell you or guide you that, okay, where the pain he feels. If it is in the syndesmotic area, your other tests, clinical examination, X-rays will also guide you to diagnose. So these are the few guidelines.
Okay, thank you so much. There is another question from Suba. It's from Nepal. He would like to know, how do you check for stability of the syndesmosis intraoperatively?
Yes, Subhas, thank you. Operatively, we have to pull the fibula up and down. If there is movement more than about a centimeter or more, so you can suspect syndesmotic rupture. But beforehand, you must see the X-ray, and clinically, you must suspect whether it's syndesmotic rupture or not. Only then you go operatively and confirm it intraoperatively.
Okay, the next question is, how do you deal with blisters? Because sometimes some surgeons like to leave them, for 1 or 2 weeks until they resolve themselves. Other surgeons like to burst them so that they can dry up quickly. and then proceed for surgery. So what is your experience with dealing with blisters?
Yeah, this is another question that goes through the world. See, blisters are treated in different places differently. Somebody will allow it to heal and dry up spontaneously. Somebody will excise. But there is a guideline in books that if the size of the blisters is more than 2 centimeter, you can excise them and wrap them, apply them. And to deal with blisters, I think X-fix would be better because you don't have to put plaster. If you put plaster, you cannot see the blisters. So if with X-fix, we can see the blisters and take care of them.
Okay, another question I would like to ask you is, as you said, the reality in our setting is the late presentation. Now you have a patient with bimalleolar fracture who comes to you 3 months post injuries. Now, what are you going to do? Are you going to do an ORIF? Because I know that it's too late for manipulation. Are you going to do an ORIF, or are you going to fuse this ankle?
Yes, there are situations like this I have come across even in my personal experience. If the patient is young and if you can see the bony fragments are very good, not osteoporotic, so you might try going for fixation. But if you feel the okay, bones are very osteoporotic, it might break up during reduction, you must tell the patient that you might have to end up with an arthrodesis. So we can plan accordingly and go accordingly.
Thank you, Dr. Kibria. Now, how do you decide in terms of syndesmotic screw, for example, or syndesmotic fixation? For how long do you keep the screw? Some people said you can remove it after 6 months. Some of people said after 3 months. What is your experience and what is the literature said? What do you advise the participant?
My advice for the participant would be to go through the AO books. Like if you are put your screws purchasing 4 cortex, it is better to remove them at 3 months before you allow them to work. If you have purchased 3 cortex, you might allow them with the screws to bear weight after 3 months. But if you think that the screws are of not good quality, it's better to remove them because it might break them inside.
Now, another question that comes from one of our participants. He would like to know about the posterior malleolar fracture. When do you decide to fix them?
Yes, Dr. Banza, posterior malleolar fracture is quite common. So you decide preoperatively that you look at the size. If it covers more than 1/3 of the articular surface, you need to fix it. You can fix it to the leg screw anteriorly, or you can fix it from posteriorly, whichever is suitable for you. And if it is less than that, you may leave it alone. So, Dr. Banza, can I ask you, can you put your comments on this? Do you want to fix this posterior malleolus a similar way, or you have a different opinion?
With on a posterior approach, if you have more than 25% displacement. So I totally agree with you.
And about the syndesmotic screws, do you have any opinion? You want to add something?
I keep them for 3 months and then I remove them after 3 months. That is my practice. Okay, the next question, it's about the tailor shift. Can you have a tailor shift without malleolar fracture?
See, with the syndesmotic rupture, you can have a tailor shift. The malleolar doesn't need to fracture. With the ligament injuries, you can have a tailor shift. If there is a medial malleolus rupture, there is syndesmotic rupture, you can have a tailor shift. Or there may be masonry fracture as well. So you can have it. Do you agree with me, or you have some different opinion?
I totally agree with you because some people feel like you can't have a tailor shift unless if there is either medial or lateral malleolar fracture. But it's not correct. You can have a tailor shift, once the syndesmotic just gives way, it can shift. Yeah, it's correct. I've got a question from one of our participants from Egypt, is Assem. It said, what do you recommend in case of open bimalleolar fractures?
See, open fracture has to deal with first, with the need to cover the bones first. That is the priority. Because you might have to go for a flap cover, maybe a free flap, maybe a cross leg flap, we don't know. So the open fracture has to treat, if you can cover the wounds primarily, so you can very early, and if the wound is not very dirty, you can go for fixation. You apply the open fracture fixations in other cases to this as well. But you must not take any chance for infection.
Yeah, I'm reading another question from Hector from Mexico. He would like to know, your experience with non-surgical treatment. I think he's talking about ankle fracture. So your experience with non-surgical treatment.
Still, I treat ankle fractures non-operatively, and I decide if they are not, as the criteria are, the patient's general condition does not permit surgery, or the fracture itself is stable, does not need fixation, and still I do non-operatively.
Yep. The next question, Dr. Kibria, is from Mr. Hank. He said, in severe soft tissue damage, how long will we wait, before you perform the operation?
See, the soft tissue damage coverage is the responsibility of the surgeon. Usually, soft tissue coverage should be replaced early, either by free flap or by cross leg flap. You need to have a plastic surgeon, or in our countries, we are trained to do the flap cover by ourselves as well. So, soft tissue coverage is the earliest possible time, depending on how much the wound is dirty. So you can, at least by 5 days, any bone should be covered. That is the principle. If it goes beyond 5 days, that means the surgeon is at fault.
I've got another question from one of our colleagues in the UK. He just said, in case you do a ligamentastasis and you apply a stable external fixators to deal with soft tissue, can you just treat it like that, definitely, like a definitive treatment, instead of converting this in an ORIF later?
You can do both. You can remove the X-fix once the soft tissue swelling has subsided. You can put into plaster. But if you must check whether there is a stable fracture, whether it's displaced, whether it needs articular reduction, so these all things will come up into issues. Even if it is a accurate reduction, but if you can see there is talar is trying to shift later on, you need to go for fixation. So that is the guide. We want to achieve ankle congruity, whether non-operatively or operatively, but the congruity is a must. So that is the key guide.
Yeah, I think I will agree with you, but also I will agree with him because sometimes when you apply the X-fix and some of the pin can start getting pin site infection, and it's already a bit of risk if you have to go in, and to ORIF your fractures. So if you manage to apply your external fixators and ligamentastasis you reduce properly and they have a stable joint, I will agree with him and agree with you. You can treat, it can be a definitive management. Yeah. And another question is coming from Alexandra from Romania. He said, do you use anticoagulation treatment in this patient?
Not necessarily. Anticoagulant treatment usually on the hips mostly. For ankle, I have never used. Dr. Banza, do you have any experience of using anticoagulants for treating ankle fractures?
we don't use, and I don't use, we use anticoagulation for, pelvic fracture, not just for the ankle fractures. Ankle fractures we don't use, but of pelvis fracture we do use. And another question from Hector from Mexico. He said, do you use sedation for reduction?
Yeah, I do. You cannot reduce, whatever the principle you apply for your relatives, you apply the same principle for your patients. So without sedation, how can we reduce the ankle? It's very difficult and painful as well.
And do you have any suggestion in terms of medication you use?
In most of the places, we use midazolam or this ketamine, or if possible, if anesthesia is available, we use the spinal anesthesia.
And I've got another question. A colleague would like to know, is there any difference in treating ankle fractures in a normal patient and patient with diabetes?
So the diabetic patients will need more care, because if you treat them non-operatively, that is also a problem. If you take them for surgery, that is also a problem. And to immobilize them for long is important non-operatively. And if you take them for surgery, infection is another problem. So diabetic patients will take more time to heal up. So you can continue your plaster of Paris for longer time, and you must take diabetes in control if you're taking him for surgery.
Another colleague, Dr. Hank, is asking, in your experience, if he doesn't have plate and screws, do you advise him to use KYS to treat ankle fractures combined with POP?
Simply, you can use K-wire and circlage wire. We have been using for long. In 90s, when I was a resident, we used to use the K-wires and circlage wires for reduction of the malleoli. And used to use Steinman pin for reduction of the talus as well. So you can do it with plaster.
Another interesting question from Mr. Ibrahim Alabi, is from Nigeria. Coming back to what we have discussed a bit before, he said, how late will you still reconstruct the ankle? In your experience?
I have done it at 7 months, personally. He had ankle fracture 7 months back with a talar fracture, neck fracture. So I had to reduce the talus, fix it. I reduced the ankle as well. But the problem is that he has not come back after 1 or 2 follow-ups. The same issue that exists all low-income countries.
Now, again, Dr. Kibria, because this is it's an issue in our setting. You said 6-7 months. That was you. Now, do you have any recommendation? You said, what is the cut of limit or time limit where you can say, a patient with 3 months or 4 months? Do you have any idea? Because this participant would like to know, up to when you can say it's too late, you can't orif this joint.
It doesn't depend on the patient's time only. It depends on the ability of the surgeon who can reduce it. It depends also on the facility that you're working in, whether you can reduce it or not, and whether you have the available implants or not. So patient must get all the benefits of the surgery. If you can give it, you can reduce it as late as it's possible. Otherwise, you have to go for arthrodesis. Even arthrodesis will give you relief of some pain, but it will make him difficult to walk on an uneven surface as well. So keep that in mind as well. Dr. Banza, do you have any time limit? You know anything you can say for us?
Okay. I've been having some challenges with this patient as well. So what I did is, after 3 months, I was trying to fuse, the ankle joint, but I didn't have good result with fusion. So what I'm trying to do nowadays is, even after 3 months, if the X-ray, the joint looks to be, good on the X-ray, I always try to fix them, just to give them a chance. Yes. That's what I'm doing.
For young patient and old patient, you can make a difference as well.
Yeah. And I think it's the same guy from Nigeria who is asking, what is your experience with primary ankle arthrodesis in a very bad ankle fracture coming late? Do you have any experience, in arthrodesis? What is your experience with primary ankle arthrodesis in very bad ankle fracture coming late?
There's a few cases, especially diabetic patient coming early because they had not many issues like diabetes was uncontrolled. They were coming early, but they were not fit for surgery. So later on, we had put them in arthrodesis, and they worked well. These were quite old women with old ages. It works well.
So this is Mr. Fazul, is from Bangladesh. He would like to know, for trimalleolar fracture, which one is the best approach?
See, trimalleolar fracture, you have to reduce the fibula first. If you can appreciate the posterior malleolus from the posterior side, that's okay. Otherwise, you have to fix it from the anterior side. So in my expertise or with my experience, I do it from the fibula from the posterior approach. I think Dr. Fazlu might have other experiences. Dr. Banza, can you say something more or add something to it?
I will agree. I agree with you. The main stage of this approach is you get the length of the fibula. Once you get the length and you fix it, and then you can approach the two other malleola and fix them. Yeah.
You want to approach the posterior malleolus separate incision or the same incision?
I'd like to approach them. I like to approach the posterior malleola through the posterior approach. I found it easy. Yeah.
You can approach it to the anteriorly also. You can put a lag screw and fix it on the anterior side as well.
And there is another question from Henry Ndasi, is from Cameroon. He said, in isolated fibular fracture and displaced widening medial clear space, will you still open the medial side or you just fix the fibular fracture side?
Can you repeat the question?
So let me just change the way he's asking the question. If you have a fibular fracture, okay, and then you have a widened medial clear space, okay, are you going to open the medial side or you will just fix the fibular side?
No, the gapping up of the medial space meaning there is a diastasis or rupture of syndesmosis. So you have to fix the fibula and fix the syndesmosis at the same time. You cannot leave it alone. Dr. Banza, do you think it's okay?
Yeah, so you mean you are going to fix both, you are going to open both sides? For example, if you have to fix, you have to open the medial side and the lateral side?
Medial side, there is medial fracture or only gap?
Yes, the medial side, there is just gap.
Yeah, that means the medial ligament might be ruptured. So, but if you fix the syndesmosis, you should be able to correct that one. If it doesn't, only then you have to open up the medial side and repair the ligament.
Okay, and do you have any experience on repairing the medial
I have never repaired any deltoid ligament.
I agree with you. If you have a widened space, medial space gap, I think once you fix the lateral malleola and you put a syndesmotic screw, you must be able to reduce that gap.
All the reduction.
Yes. So you don't. Most of the time, you don't need to open the medial side. Yeah. There is another question from again Dr. Hung. He said that in bimalleolar fracture, which malleola should be or should we reduce and fix first, and why?
That's a very good question. See, usually fibula is the denominator for ankle fractures. So usually we fix the fibula first. But there are people, those who fix the medial malleolus first, they feel it comfortable because there may be entrapment of the fragments inside. which may be a barrier to reduce. So you must be prepared to open up both sides. If you don't have a CT scan, if you don't know what fragment inside is, because many times the medial malleolus is associated with a fragment which goes inside the joint and which prevents reduction of the fibular site as well. So usually in my practice, earlier I used to open medial malleolus, but now I open up the fibula first because the position we have placed, you know that we have put a sandbag on the pelvis, so it's easier to open up the lateral side. But if you have seen, if you can appreciate there is a fragment inside the medial malleolus, you can go for the opening of the medial malleolus first. But fibula is better to fix it first time so that you get stable one side, then you go for the other one.
Dr. Kibria, there is still a lot of questions coming in, but because of the time limit we are having, I will have one more questions to go, and then I think for our other participant, we'll do it offline. So this question is from Teresa, is from Switzerland. He said, Dr. Kibria, do you see pseudoarthrosis in ankle fracture due to delay operative treatment or infection, and how do you manage it?
I have not seen pseudoarthrosis like that for delay or anything. We have seen malunion, deformities, and infection is quite. I have seen an open fractures ankle, especially the diabetic and old age patients. In one case, we had to amputate. Other cases, we had to put Elizero fixator for arthrodesis.
Thank you so much, Dr. Kibria,
Dr. Banza.
And appreciate our participant to come in with a lot of questions. But because of time, I think some of these questions will answer them offline. Once again, thank you so much.
Thank you, Dr. Banza. So after the live question sessions, we can come to the take-home messages. The ankle fractures are quite common in low-income countries. You must be able to make the correct diagnosis in the first time. Early consultation is the key to success. Earlier, the better you can reduce them. You must have careful clinical evaluation. And now you know what is a normal X-ray looks like and how to read it, because small fractures can produce big problems. I acknowledge my thanks to AO Alliance Curriculum Development Team, AO Foundation, AO Education Institute, and especially Dr. Claude Martin Jr. Switzerland to help me doing this program. Wish we all can have this sort of operation theater in future. If not, our knowledge should be available to help our patients in low-income countries. Thank you, participants. Thank you all. Before I close, I'd like to say that we have our next webinar in April 2017, and those who could not attend this webinar, we can have a recorded in the AO Alliance website. We can see that later on. Thank you all.